discuss in our classes. You see, most of the questions that are going to be projected in our classes are very much condensed, so as to include most of the relevant chapters in that topic. If you could work out one question, it is equivalent to working out 5 to 10 questions, because they are all condensed to cover most of the relevant chapters in that topic. Good coverage. First, the question will be projected, and after that, illustration will be projected, explanation will be given. Again, the same question will be projected. You will be in a position to choose the right answer for that question. Today, we are going to discuss two topics, the questions from upper extremity and lower extremity, upper limb and lower limb. First, we shall begin with upper limb. Read the first question. Oh, it has come already. Find out the right response for this question. Diagrams will be shown after this. Explanation also will be given. Afterwards, you will be in a position to choose only the right response. So this person has a stab injury in the neck. It has damaged one of these nerves. What is his difficulty? He is not able to, he is finding it difficult to over abduct his arm. Over abduction of arm has become difficult following injury to this nerve in the neck. Which is that nerve? Is the question. You can show your digits like this: 1 for A, 2 for B, 3 for C, 4 for D. I can see from the distance. Which one do you want to choose for this question? You want to go with number 2? Number 2. Okay. What made you choose number 2 for this? Paralysis of which muscle do you suspect in this case? Trapezius. You see, abduction at the shoulder can be described at 3 stages. Initiation of abduction, just up to 15 to 20 degree. This is carried out by one muscle. Which muscle you know? Supraspinatus. Supraspinatus is a muscle of the rotator cuff. It is responsible for initiation of abduction. And this muscle is supplied by which nerve? Suprascapular nerve. Easy to remember. Supraspinatus and infraspinatus both are supplied by suprascapular nerve. So if the suprascapular nerve is injured, the person is likely to have problem with initiation of abduction. So you can eliminate suprascapular nerve from the choices, because the problem is not with the initiation of abduction. Then abduction up to a horizontal level, abduction up to 90 degree. This 90 degree abduction is carried out by one muscle. You know which muscle it is? Yes, deltoid. Deltoid is the muscle responsible for abduction up to a horizontal level. We know the nerve supply of the deltoid. Axillary nerve. So if the axillary nerve is injured, the person is likely to have difficulty with abduction up to a horizontal level only. Therefore, you can easily eliminate axillary nerve also. Only 2 nerves now remain. Overhead abduction, this is overhead abduction, taking the arm above the head, taking the upper limb above the head. This overhead abduction is carried out by 2 muscles. One is trapezius, the other is serratus anterior. These are the 2 muscles responsible for overhead abduction. We know the nerve supply of the serratus anterior. What is the nerve? Yes, that is long thoracic nerve, nerve of Bell. If the nerve of Bell or long thoracic nerve is injured, again the person is likely to have the same difficulty. But this nerve runs very superficially on the side of the thorax, lateral wall of the thorax, starting from the root of the neck. This nerve is not found in the middle of the neck. It is starting from the root of the neck and descending on the lateral aspect of the thorax superficially. And this nerve is likely to be damaged on the side wall of the thorax rather than in the neck. Further, that long thoracic nerve is not given as a choice in this question. The nerve that is left is the spinal accessory nerve, which supplies two muscles. Look at this. This is the spinal accessory nerve that runs very superficially in the posterior triangle of neck, coming out through the jugular foramen along with the 9th and 10th cranial nerves. This is the 10th cranial nerve vagus, and this is the 11th, the spinal accessory. This nerve runs superficially in the neck, supplying two muscles. This is the sternocleidomastoid, which is cut and reflected to expose this area, and you can see the branches from this nerve going to the sternocleidomastoid. The other muscle is the trapezius, so the nerve descends deep to the trapezius and disappears about 5 centimeters above the clavicle, and then it supplies this muscle. So injury to the spinal accessory nerve can result in paralysis of two muscles, sternocleidomastoid and trapezius. Here, the trapezius muscle is paralyzed, therefore the person has difficulty with overhead abduction. Look at this nerve may be easily damaged if in a stab injury, or also whenever you want to drain an abscess in the neck, cervical lymphadenopathy abscess. Careless incision made in this region can easily damage the spinal accessory nerve. One must be aware of presence of such a nerve in the posterior triangle of neck, descending superficially. So, while doing IND, care must be taken not to damage this nerve. Look at the other nerve that we discussed. These are the 8 digitations of serratus anterior muscle. Serratus anterior, which begins taking origin from the first upper 8 ribs and is inserted into the medial border of the scapula. This is the nerve that supplies these 8 digitations. Long thoracic nerve, also known as nerve of Bell. This nerve you see here, it begins from the root of the neck only, runs very superficially. So this nerve is likely to be damaged on the side wall of the thorax due to a cut injury and also while doing mastectomy. The nerve that is in danger while doing mastectomy, especially radical mastectomy, is the long thoracic nerve. If long thoracic nerve is damaged, the same difficulty will be there, plus one more you can expect later. This is the muscle, serratus anterior is the muscle that holds the scapula against the thoracic wall. Our scapula is kept against the thoracic wall because of this muscle. And if this muscle is paralyzed, the scapula is no longer kept against the thoracic wall, it bulges out. What is it called? Winging of scapula also will be a finding. Further, what is the primary action of this muscle? Overhead abduction is only one action. That is not the primary action of this muscle. What is the primary action of the muscle? Protraction of the scapula. That is this movement. That is why this muscle is called box. So this muscle, serratus anterior, is also known as boxer's muscle because punching movement, protraction of the scapula is the primary action of the muscle serratus anterior. So in addition to difficulty with overhead abduction, the person is likely to have difficulty with protraction of the scapula, and soon the person will develop winging of scapula. These two difficulties also will be there if the long thoracic nerve is injured. Now, of the four choices given here, this dorsal scapular nerve is the nerve that supplies the rhomboideus muscles. Rhomboideus major and minor. They are not responsible for any of these movements. They are for retraction of the scapula, opposite of what serratus anterior does. Retraction. The two scapulae move towards the vertebral column. When the serratus anterior contracts, the scapula moves away from the vertebral column. So, spinal accessory is the right response for this question. Spinal accessory. The present day classification of axillary lymph nodes is based on their relation to one muscle. Which is that muscle? Number 3. 3 means pectoralis minor. You want to go with pectoralis minor. Okay, we shall see the diagram now. Look at this muscle. What you said is perfectly correct. Pectoralis minor is the muscle. And you can see the lymph nodes, axillary lymph nodes arranged around the pectoralis minor. You can see lymph nodes below the muscle, behind the muscle, above the muscle, on the surface of the muscle. So axillary lymph nodes are nowadays classified like this. Level 1 group means the axillary lymph nodes lying below the muscle, level 1. Behind the muscle, level 2, middle group. Above the muscle, level 3, upper group. In addition, some lymph nodes are seen between the major and minor, pectoralis major and minor. They are known as Roter's nodes or interpectoral nodes. How the lymph is drained from the breast? We know more than 75% of lymph from the breast is drained by the axillary lymph nodes. 75%. How? First, the lymph from the breast is received by the level 1 group of nodes. Then the lymph reaches the level 2. Then the lymph reaches the level 3. Like that, the drainage of lymph from the breast occurs. Majority of the lymph drains from nodes at level 1 sequentially to those at levels 2 and 3. A small amount drains to the interpectoral nodes also. So based on the relation of this muscle, the axillary lymph nodes are classified like this. Lower group, middle group, upper group, level 1, level 2, level 3. This muscle also helps to divide one more structure into 3 parts, which is that axillary artery also is divided into 3 parts by this muscle. Similarly, the subclavian artery also is divided into three parts by another muscle. You know that muscle? Scalenus anterior, correct. Scalenus anterior is the muscle that divides the subclavian artery into three parts. What is the lower limit of the axillary artery? The lower limit of the axillary artery is related to the lower border of one muscle. Which muscle it is? Teres major, perfect. Teres major, the axillary artery begins from the outer border of the first rib, where the subclavian artery ends, outer border of the first rib. It descends in the axilla and ends at the lower border of teres major. Then it becomes the brachial artery. So these are the muscles you should know. Scalenus anterior for the subclavian artery, this pectoralis major for the axillary artery, and its lower border axillary artery, teres major. So what you have chosen is perfectly correct. Pectoralis minor is the right response for this question. Here you see the axillary artery is the only source of blood supply to the entire upper limb. This is the parent artery of the upper limb. This artery is compressed by a tumor of the coracoid process. Normally one would expect cessation of blood flow to the upper limb. But you see the radial pulse in this case is normal. What does it suggest? It clearly shows that the blood flow to the upper limb is not cut off in spite of total compression of axillary artery by the tumor of the coracoid process. This explains establishment of a collateral circulation, which we have studied long back, an anastomosis on the back of scapula, anastomosis around the scapula. Some arteries anastomose here to provide blood to the upper limb following occlusion of the axillary artery. Which pair do you want to choose for this question? First of all, you know the two major arteries linked by this anastomosis and the branches of these two taking part in this anastomosis. Here comes the significance of knowing the scapular anastomosis. A bypass route is now provided for the upper limb following occlusion of the axillary artery. Which pair do you want to choose? We will see the diagram and afterwards it will become simple. Any idea? Any pair you want to choose for this question? Number 4, okay. Then number 3, alright. Number 3, number 4. Subscapular and posterior circumflex femoral, suprascapular and subscapular. Alright. Anything other than 3 and 4? Okay, we will see the diagram now. Look at this. This is the subclavian artery, first part. This is the axillary artery, third part. And here is our coracoid process. The coracoid process compresses the middle part of the axillary artery, say second part of axillary artery. Second part of axillary artery is now compressed. Blood can flow this way. This branch of the subclavian artery, first part of the subclavian artery runs above the scapula and anastomosis with this branch somewhere here, and which is actually a branch of third part of axillary. So blood can flow this way to reach the third part of axillary. One more you can see here, this is another branch coming from the first part of the subclavian. It runs on the dorsal aspect of the scapula and anastomosis near the inferior angle with this artery, which is again a branch of the third part of axillary. So two routes have been established following occlusion of the axillary artery. Bypass route. part, this is an anastomosis linking the first part of subclavian artery with the third part of axillary artery. That you should know. This is the artery that runs above the scapula, therefore called suprascapular artery. It anastomoses with the subscapular artery because this artery runs below the scapula, and this is the site of anastomosis. This particular branch of the subscapular artery winds around the scapula, therefore called circumflex scapular artery. So this is an anastomosis between the first part of subclavian and third part of axillary. The branches of the first part of subclavian anastomose with the branches of third part of axillary. That is how blood reaches the third part of axillary, then the rest of the upper limb. That is why the radial pulse of the person is normal. The middle part of the axillary artery is compressed by the tumor. So whenever there is an occlusion to the middle part of the axillary artery, blood supply to the upper limb will not be cut off because of this anastomosis. Now we will see the other artery taking part in this anastomosis. You know the branches of the axillary artery, then only you will be in a position to eliminate the distractors. You have seen several arteries in that question. First of all, you should know what they are, from where they come. An easy way to understand the branches of the axillary artery. First part gives one branch. Second part gives two branches. Third part gives three branches. Easy to remember. Look at this, we will enumerate the branches later. This is the other artery that runs on the dorsal aspect of the scapula from the first part of subclavian. Since it runs on the dorsal aspect of the scapula, it is known as dorsal scapular artery, also known as deep branch of transverse cervical. This artery anastomoses with the continuation of the subscapular artery. That is called thoracodorsal artery. And this is the site of another site of anastomosis. So blood can reach this artery this way and also this way. So if an occlusion occurs to the axillary artery above the origin of subscapular, that is anywhere here above this level, anywhere above the site of origin of subscapular artery, blood supply to the upper limb will not be cut off. On the other hand, if the axillary artery is occluded below the origin of the subscapular artery, the blood supply to the upper limb will be almost cut off. We have to amputate the upper limb. That is the only way. So which is the crucial site? The site of origin of subscapular artery. Any occlusion above this level will not jeopardize the blood supply to the upper limb. Below this level will cut off the blood supply. So what are the branches of the axillary artery to eliminate the distractors? First part I told you, giving one branch. This is the uppermost artery in the thorax. That is why it is called so. Supreme thoracic artery or superior thoracic artery. Which are the two branches of the second part? Thoracoacromial and lateral thoracic. Acromiothoracic and lateral thoracic. This way also you can tell, no problem. Acromiothoracic and lateral thoracic. Which are the three branches of the third part? They are shown in the picture. Look at this, one branch we have already labeled the subscapular artery. The two branches encircle the surgical neck of humerus, that is why they are called so. Anterior circumflex humeral, posterior circumflex humeral. They form a circle around the surgical neck of humerus. So this way we have three branches coming from the third part of axillary artery. Now we shall go back to the question. Now it is easy for us to eliminate the distractors. So this is an anastomosis between the first part of subclavian and third part of axillary. That you should remember. We shall see the anterior and posterior circumflex humeral. You may laugh at it because both of them are branches of third part of axillary. No use. Subscapular and brachial, no such anastomosis exists. Subscapular and posterior circumflex humeral, some of you chose before. Now you know very well, both of them are branches of third part of axillary. There is no use. Thoracoacromial and supreme thoracic. Supreme thoracic are the branch of first part. Thoracoacromial, the branch of second part. But this anastomosis is between the subclavian and axillary, so no use. And therefore, this pair is perfectly correct. Subscapular, suprascapular and subscapular. We have seen one more site of anastomosis. You replace this pair and put another pair in that place. Which pair will you put? Dorsal scapular and thoracodorsal. Correct. So there are two sites of anastomosis. Right. This person falls on outstretched hand. Might have studied in orthopedics. When a person falls on outstretched hand, the bones that are likely to be fractured. Clavicle at the junction between its two curvatures, medial 2/3 and lateral 1/3 may be fractured. Humerus can be fractured above the condyles. What's the problem? Humerus can be fractured, supracondylar fracture of humerus. Lower end of the radius can be fractured, Colles fracture. Carpal bone can be fractured. The one which is commonly fractured when a person falls on outstretched hand, he will see. Here the physician is able to elicit tenderness between two tendons, the tendons of extensor pollicis longus and abductor pollicis longus. What is this area first of all called? Anatomical snuff box. Correct. So the physician is able to elicit tenderness in the floor of the anatomical snuff box following fracture of a bone over there. Which bone is fractured in this case is our question. Which one you want to choose for this? Number 2, number 3, number 1. Oh, radius, scaphoid, first metacarpal. Alright, number 2. Well, we will see that area first in the photograph. Yes, here we see this tendon which is responsible for extending the thumb. That is why it is called so. Extensor pollicis longus. This tendon is to abduct the thumb. Therefore, abductor pollicis longus. So this anatomical snuff box is the shallow depression between these two tendons. The floor of the anatomical snuff box is related to 4 bones. You will see them now. Which are the 4 bones related to the floor? This bone is the lateralmost bone of the proximal carpal row. From the thumb side, 4 bones, which are they? Proximal row and distal row. This is the lateral most bone of the proximal row. Which bone is it? Huh? Scaphoid, correct. Scaphoid. Then comes the lunate, trichotrum, pisiform are the four bones of the proximal row. Which are the four bones of the distal row? The lateral most bone is there now. This is the lateral most bone of the distal row. Trapezium. Perfectly correct. Trapezium is the lateral most bone of the distal row. Trapezium, trapezoid, capitate and hamate are the four bones of the distal row. In addition to these carpal bones, we also see the styloid process of the radius plus the base of the first metacarpal bone. These are the four bones related to the anatomical snub box. Of the four, the one which is commonly fractured is this bone. This bone has two expanded extremities. This end is expanded, this end also is expanded, and the middle part is narrow. That is the isthmus. Which bone it is? Scaphoid is commonly fractured, and you can see the appearance of a swelling in the region of the anatomical snub box. Scaphoid. What is the other name given to the wrist joint? Radiocarpo-ulnar joint, am I right? Is it called radiocarpo-ulnar joint or simply radiocarpal joint? Radiocarpal joint, because ulna, you see the ulna here, it does not take part in the formation of wrist joint. The radius articulates with three carpal bones. Which are they? Scaphoid one, lunate the next, and the trichotrum. These are the three carpal bones articulating with the radius to form the radiocarpal joint, the wrist joint. Ulna does not take part in the formation of this joint because there is an articular disc here in this area. This disc intervenes between the ulna and the carpal bones. That is the reason why it is not directly involved in the formation of this joint. Articular disc is there between the ulna and the carpal bones, fibrocartilaginous disc. How will you confirm the fracture of scaphoid? You will take an X-ray of this region, wrist. AP view or lateral view? Which view will you choose? Is it AP or lateral? It is neither AP nor lateral. It is oblique view. Oblique view means this is also oblique, this is also oblique. Wrist joint can be made oblique in radial deviation and also in ulnar deviation. In both sides, oblique only. But which oblique is radial deviation or ulnar deviation? Ulnar deviation. Look at this. This is the pisiform bone, the last carpal bone, smallest of all carpal bones. What are the other peculiarities of the pisiform? Smallest of the carpal bone, and this is the last bone to ossify. When? 12th year, correct. 11th year in females and 12th year in males. What is the other peculiarity of this bone? It is a sesamoid bone, correct. Pisiform is a sesamoid bone developing in the tendon of flexor carpi ulnaris. Which is the largest sesamoid bone in our body? Patella, developing in the tendon of quadriceps femoris. Quadriceps femoris. This is developing in the tendon of flexor carpi ulnaris. Unlike other bones, this bone, pisiform, has no periosteal covering. No periosteum for this bone. There is no periosteum. Devoid of periosteum, sesamoid bone, smallest of the carpal and the last to ossify. MCQ can be set based on this. So we have to take an oblique view of the wrist joint like this. Why? This picture will tell you. If you take a routine X-ray in AP view, this fracture line is not so conspicuous. But if you do the same thing in oblique view, you can see the fracture line which is very clear. That is the reason why we must take this X-ray in oblique view, otherwise we are likely to miss the diagnosis. The fracture line may be missed. What is the complication of this scaphoid fracture? Avascular necrosis. Perfect. Look at this. This is the reason for avascular necrosis. Following fracture of the scaphoid, the blood vessel supplying the scaphoid is confined to the distal fragment. The proximal fragment is deprived of its blood supply. There is no blood vessel to supply the proximal fragment now. The blood vessel which was supplying the entire scaphoid is now confined to the distal fragment only. Therefore, the proximal fragment is deprived of its blood supply and undergoes avascular necrosis. This is the usual site of fracture, but may be fractured anywhere in this picture. In this picture you can see the 4 other sites also, but this is the usual site of fracture of the scaphoid, the narrow region between the 2 expanded ends. So what we have chosen is perfectly correct. Scaphoid is the answer for this question. In addition, we have learned several other things also along with this question. These are the structures crossing the anatomical snub box. Which one you want to eliminate from the list? Number 4. Number 4. 1 also. Alright. We will see the diagram now. You can see 3 colors. The snub box is crossed by 3 structures. A vein. Which vein? Cephalic vein. The nerve, radial nerve, superficial branch of radial nerve, and the artery, radial artery. The radial, one vein, one nerve, one artery cross the anatomical snub box. The tendon of extensor pollicis longus forms only a boundary. It's not a structure crossing the anatomical snub box. It is the structure forming a boundary of the anatomical snub box. The radial nerve here becomes very superficial and therefore can be easily palpated in all individuals. This is really useful to diagnose cases of Hansen's disease. Superficial nerves in our body can be examined for thickening in Hansen's disease, leprosy. There are 2 nerves in the upper limb which can be palpated easily. Yes, this is the nerve, superficial branch of radial nerve. The other nerve is ulnar nerve behind the medial epicondyle. This nerve you can palpate even now. Very simple. All you have to do is just extend your thumb like this. Thumbs up position. Thumbs up. You can make this tendon prominent. By extending the thumb, you can make the tendon of extensor pollicis longus prominent. The tendon becomes automatically prominent when you extend the thumb. Using the index finger of your other hand, keep the index finger of your other hand over the tendon, somewhere near the middle or very close to the wrist, and just roll over the tendon. In the direction of the tendon, parallel to the tendon, you make up and down movement. You will feel something. Not in the opposite direction, it should be in the direction of the tendon. This rolling movement should be in the direction of the tendon. You can feel something touched by your finger. This is the superficial branch of radial nerve, invariably felt in all individuals and is very much thickened in leprosy. Which is the nerve that can be palpated in the lower limb? Common peroneal nerve, where it winds around the neck of the fibula, a common site of injury to the common peroneal nerve due to fracture of the neck of fibula or a cut injury on the side of the knee can damage. There are some nerves in the head and neck which can be palpated for thickening. Two nerves in the forehead region, supratrochlear and supraorbital. A nerve crossing the angle of mandible, very important. Which nerve crosses the angle of mandible? A cutaneous nerve. Great auricular nerve. Great auricular nerve innervating the skin over the angle of mandible. That nerve is a cervical nerve, C2, C3 ventral ramus. And this nerve is very much thickened. In a well-established case of leprosy, you need not even palpate this nerve. It is visible. It is enlarged to such an extent that it becomes visible. So these are the nerves which are placed superficially in our body, therefore can be examined for thickening. Sometimes the supraclavicular nerves also can be palpated, crossing the clavicle from above. Supraclavicular nerves running 3 branches. Medial, intermediate, lateral branches can be palpated, can be seen sometimes. So of the 4 structures listed, this is not the one that crosses the box. Yes. So if you are determined to learn, no one can stop you. This question is very much condensed. 25% of upper limb is condensed in this question. This question has been asked previously in your entrance exam. All about the radial nerve in the arm. Which statement about the radial nerve injury in the lower part of spiral groove is true? No idea. We know the radial nerve is a branch of the posterior cord of brachial plexus, getting contribution from all ventral rami forming the brachial plexus. Root value C5, C6, C7, C8 and T1. And this nerve enters the arm from the axilla and runs in the radial groove. Then what does it do? It leaves the radial groove to enter the cubital fossa, where the nerve terminates. How? By dividing into 2 branches, deep branch and superficial branch. We have seen the superficial branch already. Deep branch runs in the dorsal compartment of forearm. This is the nerve that supplies all extensor muscles in the upper limb. Extensor, any muscle with the name extensor will be supplied by the radial nerve. Any muscle begins with the term extensor is supplied by the radial nerve, innervating all muscles extending the joints of the upper limb. Very simple. Which is the muscle responsible for extending the elbow? Triceps. Triceps is the only muscle extending the elbow. How many heads does it have? 3 heads. Long head, medial head and lateral head. All 3 heads of the triceps are supplied by the radial nerve. Radial nerve is injured. Can you expect paralysis of all 3 heads of the triceps? Unconeus is a muscle seen on the back of the elbow. A small muscle. It is also supplied by the radial nerve. And extensor, what is that? Paralysis of? Extensor carpi radialis longus and extensor carpi radialis brevis. These are the 2 muscles extending the wrist joint, and they are also supplied by the radial nerve. So all these things are supplied by the radial nerve. What about the pronation of the forearm? Pronation of the forearm is carried out by two muscles which are known by their action. That is why they are called so. Pronator teres and pronator quadratus are the two muscles responsible for pronation. What about their nerve supply? They are supplied by the median. Now therefore you can immediately eliminate number 4. Because radial nerve has nothing to do with the muscles responsible for pronation of the forearm. Pronator teres and quadratus are supplied by the median nerve, so you can eliminate number 4 immediately. Only 3 things left now. We shall see the diagram to confirm which is going to be the true response for this. This is the radial nerve in the lower triangular space accompanied by the profunda brachiae artery. The profunda brachiae is the first branch of brachial artery, the largest also. You can see the nerve running in the radial groove. This is the muscle long head of the triceps. And this is, we have to cut this muscle to expose the radial nerve in the radial groove. This muscle is cut to expose the radial nerve in the radial groove. Which head is this? Lateral head. And this is the medial head of the whole thing, starting from here. Whole thing is the medial head of triceps. Now we shall closely observe the diagram. You can see the long head is supplied by 2 branches here. You can see that. Even before entering the radial groove, the radial nerve gives off some branches to the long head of the triceps. So long head of the triceps is unlikely to be affected if the radial nerve is injured in the radial groove, wherever it is, upper part or lower part. Here in our question it is lower part, therefore unlikely to be damaged, unlikely to be paralyzed. Now we shall follow this particular branch. This branch of the radial nerve is given when the nerve is in the upper part of the radial groove, or soon it enters the radial groove. As soon as it enters the radial groove, it gives us this branch. Let us follow this branch. This branch gives this nerve gives branches to the medial head of the triceps throughout. After that it descends in the elbow, back of the elbow, descend, trace it down. This is the muscle unconeus. It supplies the unconeus muscle. Starting from the upper part of the course of the nerve. This branch is a very long branch, supplying not only the medial head of the triceps but also the unconeus. A very long branch supplies the unconeus muscle. So can you expect paralysis of unconeus if the radial nerve is injured somewhere here in the lower part of the radial groove? No, because this branch to the unconeus is given off when the nerve is in the upper part of the radial groove. Now we shall see the innervation of the lateral head. See, the lateral head is supplied by, you can see, by the branches of the radial nerve in the upper part, not only in the lower part but also in the upper part. You can see that. You can see 2 branches are given when the nerve is in the upper part to the lateral head. So one thing is now clear. All 3 heads of the triceps are supplied by the radial nerve before it reaches the lower part of the radial groove. That's what we understand from this. All 3 heads of the triceps are supplied by the radial nerve in the upper part of the radial groove. One long head even before reaching the radial groove. So can you expect paralysis of the triceps in this case? No, because all 3 heads will be spared if the radial nerve is injured in the lower part. Then what does the radial nerve do after this? It pierces the lateral intramuscular septum. You can see this is the lateral intramuscular septum. The nerve disappears deep to it. Where it is in this septum, it gives branches to these 2 muscles, extensor carpi radialis longus, extensor carpi radialis brevis, are the 2 muscles going to the wrist. And they are supplied by the radial nerve after leaving the radial groove. So if the nerve is damaged in the radial groove, these two muscles are definitely affected, will be definitely paralyzed. They will be paralyzed. They will not be spared, they will be paralyzed. So we have understood several things from this picture. Unconeus is supplied by a branch well above. All three heads of the triceps are supplied by the nerve before it reaches the lower part. After reaching the lower part, the nerve gives off branches to the extensor carpi, radialis, longus and brevis. All points we have observed. Now we shall see the question again. Can you expect, number one, sparing the nerve supply to the extensor carpi, radialis, longus? No, cannot be spared. It will be definitely affected. Results in paralysis of unconeus muscle. Can you expect? No, not possible. Leaves extension at the elbow joint intact. Yes, that is perfect. Because all three heads are not affected. So this is the only true statement among the four. Leaving the extension intact. It is a clinical observation. Even if the nerve is injured in the lower part, extension of the elbow is not affected. Unconeus muscle is not paralyzed, which is also a weak extensor. So we have learned all about the radial nerve in the arm and the muscle supplied by it. 25% of upper limb. This is what we see in the posterior compartment of our arm. The three heads of the triceps and the radial nerve in the radial groove. That's all. Triangle of auscultation. It is a shallow area not covered by bulky muscles where you can hear the breath sounds much better than in any other area on the back on auscultation. That is why this triangle is called triangle of auscultation. Where do we keep our stethoscope on the back? Medial to the scapula or over the scapula or lateral to the scapula? Always medial to the scapula. In the interscapular space between the two scapulae. So medial border of the scapula will be definitely a boundary of this triangle, no doubt, because always medial to the scapula. Which one you want to eliminate from the list now? I have given you a clue. Number two. Number two. Perfectly correct, because this is a gap between two large sheets of muscles. Two large muscles. Which are they? Let us see. This muscle, this is the triangle. So medial to the scapula, medial to the scapula. It is a gap between two large muscles. This muscle, large muscle, is the trapezius, which forms the upper boundary, and this muscle, latissimus dorsi, which forms the lower boundary. So there is a gap between these two muscles. This gap is filled by rhomboides major, not minor. This is the rhomboides major muscle, which forms the floor of the triangle, but rhomboides minor is here. They are under the cover of trapezius on this side. So rhomboides has no role to play in the formation of this triangle. Rhomboides minor. What you have chosen is perfectly correct. This muscle takes origin from the thoracolumbar fascia. It goes up to be inserted into the humerus. Into which part of the humerus? Intertubercular sulcus, bicipital groove, floor of the bicipital groove. Three muscles are attached to the bicipital groove. There is a tip used for these muscles, a lady between two majors. Lady is the latissimus dorsi, two majors are the pectoralis major and teres major. So three muscles are attached to the bicipital groove, therefore they have a common action. That we will discuss in the next question. This is Rhomboides minor. In a case of injury to the thoracodorsal nerve, which of the following may be difficult to carry out? Lifting a heavy object from the ground, climbing a tree, carrying a heavy object on the shoulder, pushing a heavy door to open. First of all, you should know the muscle supplied by the thoracodorsal nerve, then its action. Only then you will be able to find out the right answer for this question. Thoracodorsal nerve, a branch of posterior cord of brachial plexus, supplying one muscle. Which muscle it is? We have seen this muscle just before. Latissimus dorsi. What is the action of the latissimus dorsi? That's why I told you these three muscles are attached to the intertubercular sulcus and therefore they have a common action. Lifting a heavy object from the ground. If you want to lift a heavy object from the ground, our limb must of all should be extended. All joints must be extended. Only the interphalangeal and metacarpophalangeal joints should be flexed to keep. And when you lift an object, the vertebral column should be straightened. Which are the muscles responsible for straightening the vertebral column? Erector spinae group of muscles. Erector spinae. So erector spinae are not supplied by thoracodorsal nerve. So you can eliminate that choice. Carrying a heavy object on the shoulder, which is the muscle forming the prominence of the shoulder. Athletes can produce this muscle bulge. Two bulgings they can make two bulgings on the shoulder like this. Deltoid. Deltoid is the muscle responsible for the prominence of the shoulder. If this muscle is paralyzed, drooping of the shoulder, flattening of the shoulder will occur. So this is the muscle that is used for carrying a heavy object on the shoulder. What is the nerve supply of this muscle? So you can eliminate that distractor also. Pushing a heavy door to open. Which muscle is required for pushing? Just now only we studied Serratus Anterior. Serratus Anterior is the boxer's muscle responsible for protraction of the scapula. So that muscle is supplied by long thoracic nerve. Therefore you cannot choose that. What is left now? Climbing a tree. What is required for climbing tree? You have kept the two upper limbs above your head on the stem of the tree and you have fixed your hands on the stem of the tree. What is the next step to climb the tree? Elevating the trunk. Now the trunk must be elevated after fixing the hands above the head on the stem of the tree. Which are the muscles required for elevating the trunk? That in other words, adduction of the upper limb. Here the limb is fixed, trunk is elevated, effect will be the same. What is adduction? The upper limb is moved towards the side of the trunk. This is adduction. Here upper limb is fixed, trunk is moved up to produce the adduction. So which are the muscles responsible for adducting the upper limb, arm to the side of the trunk? Our Lady between two majors. These are the three muscles required for that. They are the powerful adductors of upper limb, adductors of arm at the shoulder. Pectoralis major, teres major and latissimus dorsi. Of the three, the latissimus dorsi is the most powerful adductor. That is why this muscle is called climber's muscle. The muscle becomes very much active while climbing a tree. You can see when the person is lifting the trunk after fixing the hand, the trunk becomes triangular. That triangular part is produced by the latissimus dorsi. The muscle becomes muscle contracts and the trunk becomes triangular. So this latissimus dorsi is supplied by the thoracodorsal nerve. So which is the right answer for our question? Climbing a tree. The other movement required in addition to adduction is internal rotation of arm, medial rotation. These three muscles, since they are attached to the common site in the humerus, they also medially rotate the arm. So adduction and medial rotation of arm. These two things are required while climbing a tree, and these two things are produced by the three muscles attached to the common site of the humerus. Yes. The median nerve lies very close to one of these tendons. And sometimes the tendon and the median nerve will have equal same caliber. And one may be mistaken for the other. Tendon may be mistaken for the median nerve and median nerve may be mistaken for the tendon. But their relation is quite specific. Tendon of which muscle serves as a useful guide to locate the median nerve in the wrist? You come across a case of wrist slash where there is tendon injury. Nerve injury also possible. You want to identify these tendons and the neurovascular structures in the wrist before closing the wound. So you should be in a position to identify the median nerve in relation to this particular tendon. Which tendon is this? Number 3, Palmaris longus. Number 2, Flexor digitorum superficialis. Number 4, Flexor carpi radialis. Only 2 things are left now. Anybody for ulnaris? Well, we will see the diagram to confirm everything. The median nerve and this tendon run together. The radial artery and this tendon run together. The ulnar nerve and this tendon run together. So the neurovascular structures can be identified in relation to the tendons in the wrist. This is the median nerve and the tendon is Palmaris longus. It runs in close relation with Palmaris longus tendon. The radial artery runs in close relation with the flexor carpi radialis tendon. The ulnar nerve runs in close relation with the flexor carpi ulnaris tendon. I told you the median nerve and Palmaris longus tendon may have the same caliber. So if you do not know the exact relation, You may think the median now is the palmaris longus tendon and the vice versa. So this should not occur. Then how will you differentiate these two? Here comes their relation. You see, we have seen three structures here: ulnar nerve, median nerve and radial artery. They keep this relation. They run lateral to their respective tendons. The term lateral must be underlined. The lateral structure will be the neurovascular structure. Medial structure will be the tendon. That is the relation they keep. You see, the median ulnar nerve runs lateral to the flexor carpi ulnaris. Median nerve runs lateral to the palmaris longus. Radial artery runs lateral to the flexor carpi radialis. So they keep a lateral relation to their respective tendons. We feel the radial pulse between two tendons. You can see two tendons on either side of the radial artery. Which are the two tendons? This side we see the flexor carpi radialis. This side, this tendon. Which tendon is this? Brachioradialis. So, radial artery runs between two radialis tendons, flexor carpi radialis and brachioradialis. And you can see them. You can see the groove produced by these two tendons, and that is the site of palpation of the radial artery. Now I am going to ask you one question. In a case of wrist slash for committing suicide, which of these structures is least likely to be damaged? I am going to give you the choices. A case of wrist slash, which of these structures is least likely damaged? Now question, I have not given you the choices. How can you say it is median now before choices are given? Now first thing is radial artery. Next is the flexor carpi radialis. Third, median nerve. Fourth, palmaris longus. Radial artery, flexor carpi radialis, median nerve, palmaris longus tendon. Of the four, which is least likely to be damaged? Definitely what you said before is perfectly correct. Median nerve is least likely to be damaged because it not only lies lateral to the palmaris longus but also deep to it. So in a case of wrist slash, median nerve usually escapes. Now suppose median nerve is not given, instead ulnar nerve is given. What will you do? Ulnar nerve is likely to escape because while committing suicide, the person always starts the cut, begins the cut from the radial side, whether the person is right-handed or left-handed, irrespective of the hand, begins the cut from the radial side. By the time the cut reaches the ulnar side, it becomes superficial, unless the person is very much determined to die. So ulnar nerve escapes. Other structures are damaged. The cut becomes very superficial when it reaches the ulnar side. Starting point, it will be very deep. That determination will be there. Radial artery must be cut, otherwise it is an unsuccessful attempt. So these are the things useful whenever you want to do any surgery here. Reconstructive surgery of tendons of hand in case of leprosy, we must know how to identify these neurovascular structures in relation to their tendons. So this is the right answer for this question. Palmaris longus tendon is an inconstant tendon. It may or may not be present. This is the tendon that expands to form the palmar aponeurosis. The corresponding tendon that we see in the lower limb is Plantaris, correct. Plantaris is the muscle similar to palmaris longus in the upper limb. It is also an inconstant muscle, plantaris. And these two tendons are often used for reconstructive surgery of tendons of hand because they are not that much useful. We can cut the tendon of palmaris longus or plantaris and transplantation can be done. Tendon transplantation. Cervico-axillary canal is a triangular gap. It is through this gap the neurovascular structures in the neck enter the free axilla. Which one you want to eliminate from the list? Any idea? Very simple. It is a triangular gap. The brachial plexus, other blood vessels enter the free axilla from the root of the neck through this gap. It is called the apex of the axilla. One. Okay. One. What else? Look at this picture. The arrow has passed through the cervico-axillary canal. We know the bone which is in front of our thorax is the clavicle. Which bone do we see behind? Scapula. So it is a gap between the front bone and back bone. Back bone means scapula, not the vertebral column. Limited medially by the first rib. So bounded in front by the clavicle, behind by the upper border of scapula, limited medially by the first rib. Head of the humerus is not seen anywhere here. It is far away from that area. So it does not form a boundary. Therefore, head of the humerus is the right response for this question. Break. Child break என்ன கொடுக்கணும்? சரியாயி கொடுக்க. Yes, if you expect less than other, no more frustration, disappointment. Okay, we shall discuss this question after tea break. Tea is ready now.